do with symptoms. And first of all, you've got to do all the basic stuff. Before you ask for your investigations, before you get your OCT, which is not the answer to all diagnostic ills, before you get your electrophysiology, you examine the patient, you take a history. Sometimes you'll have to examine other bits of the body. God forbid you might have to examine feet or hands. You know, ophthalmologists get used to examining eyes, but if you've got cardiopedal, you look at polydactyly, you've got Refson disease, you've got these strange forked toes, you might have to examine other bits of the body. Take an accurate and complete history, which must include family history, surgical history, drug history, medical history, etc. And the symptoms then need to be refined. Most patients who come along and say, doctor, I can't see, there's a bit which needs adding on. So, doctor, I can't see in the dark, which might suggest retinal rod system problems. Can't see to read, could be macula, optic nerve, intracranial, brain, etc. In bright lights, cone system problems, optic nerve, brain, etc. So refine where you're going and then investigate accordingly. Get your questions down so you ask questions that need to be answered. Now that leads on to the next one, which is medically unexplained visual loss, which is, doctor, I can't see, but you can't see why. And that's much more of a challenge, because the issues there are retinal or macular dysfunction with the normal fundus, and we've seen examples of cone dystrophy where the fundus was normal, the OCT was normal, the imaging was normal. Fundus abnormal, and of course any CSMB patient, night blindness is the main problem. If the fundus is abnormal, the symptoms are unexplained. And we've all seen patients who've got very small changes of macula, and they're elderly patients, and you think, oh yeah, they've got early age-related macular degeneration. And then you think, oh, well, I'll do a visual field just in case. And they've got a bitemporal hemianopia, and behind the globe, they've got a non-functioning pituitary adenoma, which gives you the reason that the cures will last, not the maculopathy. So do the fields carefully, do them appropriately. Don't just rely on Humphreys. 24 degrees is not always enough. You need to look at the Goldman sometimes, etc. Of course, you can have neurological disease. You may or may not see afferent pupillary defects. Afferent pupillary defects can occur in maculopathy, they can occur in retinopathy, they can occur in optic neuropathy. And if you've got both optic nerves, you don't necessarily see a relative afferent defect either. So always be cautious of making a diagnosis of non-organic visual loss, because that's the route you go down. So of course, again, electrophysiology, objective demonstration of function. So what do we get? We have got optic nerve disease. Well, the really important stuff was done by Martin Halliday's group at Queen Square in London. A series of papers, beautiful papers, very, very wonderful science. He firstly showed that reversal leak was delayed in optic neuritis, acute manifestation of optic nerve demyelination. That delay remained after the acuity had recovered, but most important of all, and this fundamentally changed neurological practice at the time, was that you could get subclinical delay. So an eye with no signs or symptoms of optic nerve disease could still show a conduction delay. This absolutely revolutionized neurological practice. Pattern ERGs we've seen extensively used so far in assessment of macular function, but I also suggest that their origins are in the ganglion cells. So what happens if we have ganglion cell disease? I showed a pictogram which said you're going to lose N95. Well, this is a patient who's got unilateral optic nerve conduction delay and who has a normal N95 P52 contact. So in this instance, there is no evidence of significant retrograde degeneration to the retinal ganglion cells. In contrast, this patient, beautiful P50, unilateral loss of N95, unilateral delay. So this patient has got significant retrograde degeneration to the ganglion cells from the optic nerve. And this patient has no VEP detected. Very occasionally, a patient following optic neuritis does not recover visual acuity. Because pattern ERGs are done binocularly, the good eye maintains fixation, maintains accommodation, you get a beautiful P50 in the affected eye with loss of N95. And indeed, the last case which we ended up with the chiasmal infiltration, you could get P50 even from a blind eye. And this is another example of that. This is a patient with a large pituitary tumour, no detectable pattern VP, no detectable flash VP, delayed VP on the other side, loss of N95 on the left, some P50 involvement on the right. But now look at that shape. We know that shape is important. When we look at the shape here, comes up sharply, tails off. Remember the shape, and note that P50 is shorter than normal. This is what happens when you block spiking cells to show the toxin, the active ingredient fugu, pufferfish, which people think is great to eat because you get this tingling and you risk your life. It doesn't taste good. That's the reason to eat it. And you get a short P50. Because what happens is you lose the ganglion cell contribution. So as you progressively lose the bit that causes N95 to develop, so P50 gets shorter. You start off by losing a bit of this, a bit of that, until you get left with this. It never, ever disappears in optic nerve disease. So if you get no detectable pattern ERG, it is not optic neuropathy, providing fixation is maintained and providing the patient is appropriately refracted. 45-year-old referred with nobody knew. She's got variable fields, slightly abnormal Ishihara, not a good test of colour vision, but it was marginally abnormal. And the referral was to establish normal optic nerve function. And then we do the VP, and it's delayed. So this could be interpreted as identifying the optic nerve disease that we were supposed to exclude. But as we mentioned previously, VPs come from the back of the head, they are not specific. So you do your pattern ERG, and your pattern ERG is profoundly subnormal, so this is a bilateral macula. You therefore have to test retinal function. Is it isolated macula? Is it generalized retinal disease with macular involvement? So the ERG comes into play. Rods, normal, cones, flicker, delayed, reduced, so this is a cone dystrophy. And this is another cone dystrophy with completely normal imaging. The fundus is normal, the discs aren't pale, the autofluorescence is normal, the OCT is normal, and the patient's got a cone dystrophy. Never believed the equivalence between normal imaging and normal function. You want to find out whether somebody's got functional loss, non-organic visual loss, you can't just image them. Patient who came in following dengue fever, went to Thailand, fantastic place, got dengue fever, comes back to London, develops unilateral visual loss, turns up with its casualty, has an afferent capillary defect, has completely normal autofluorescence imaging and completely normal fundus examination, and has 636 vision. And you do the VP, and the VP is delayed, broadened, and reduced. The other eye is completely normal. But again, the normal fundus does not mean normal function. So you have to test the macula, and then you see the macula is down. So it is a maculopathy even with a normal autofluorescence image, even with normal fundus. And those of you familiar with dengue will know that it usually produces a maculopathy, but it's a hemorrhagic maculopathy which you can see easily. You do the ERGs, they're completely normal. So the dysfunction is confined to the macula. And then the multifocal ERG shows you the extent of the lesion. And if we think in terms of anatomical correspondence, here we've got the optic disc, here we've got the fovea. So when we're imaging the right eye with autofluorescence, we're looking at this, except it doesn't work. It images normally, but it doesn't work. And what are the retinal disorders we're most likely to be mistaken for optic neuropathy? Well, the first two, an ophthalmologist is not going to get wrong, shouldn't. But the neurologists will, because they don't use a slit lamp. They just use a direct ophthalmoscope, and they can be forgiven for messing posterior scleritis. That's a difficult diagnosis anyway sometimes. The patient has pain, main worse eye movement sometimes, so it mimics a retrobulbar neuritis. Central serous, you can always tell neurologists take fundus photographs because the disc is in the middle. So they don't look at the macula. So they're concentrating on the disc. So ophthalmologists will not miss those. But cone dystrophy, as we've seen before, normal fundus or pale discs, all central retinal artery occlusion with severe retinal artery can be mistaken, as we saw earlier. Azure, occult maculopathy, possibly related occult macular dystrophy with RP101 mutation, autoimmune paraneoplasty. Is there anything about the VEP which enables us to resolve the difference between the two, between optic nerve disease and between macular disease? And the answer, sadly, is no. This is a series which I published a long time ago now, looking at a whole bunch of macular disease patients, a whole bunch of multiple sclerosis patients, and 10 millisecond delay, 20, 30, 40 in macular disease, it's common. There's nothing that you can do with the VEP. I don't like these things, you cough and everybody dies. There's nothing you can do purely on the basis of peak time shift. Whereas when we look at pattern in the same group of patients, by the time we've got 20 millisecond delay, P50 is less than a micron. So we've got pretty good means nearly always for distinguishing between the optic nerve disease and the macular disease. This is a patient who was assumed to have non-organic visual loss, referred up from casualty by someone who's now an internationally famous retinal doctor. I won't say who. Painful right visual acuity loss, but mother and sister have both got multiple sclerosis. The patient herself has been in and out of psychiatric hospital. She's got reduced visual acuity and no signs. In particular, there's no relative atrophic pupillary defect. We were asked to confirm non-organic visual loss. And we didn't, because the affected eye shows profound delay, the unaffected eye shows profound delay. And this is the subclinical demyelination which Martin Haller first described, which is so important. So you've got delay on the symptomatic side, massive delay, 130 compared with normally 100 on the asymptomatic side. So there's no relative atrophy because both eyes are involved. If you're doing casualty or you're teaching casualty, doctors what to look for. Patient comes in with no signs but symptoms of optic nerve disease. Always consider the possibility of bilateral disease before you send them away with a diagnosis of non-organic visual loss. Now, non-organic visual loss, of course, is common. We see quite a lot of it. Sometimes it's deliberate, sometimes it's psychogenic. That's not the role of the electrophysiologist. We can't do that. The role of the electrophysiologist is reasonably straightforward, because our job is to reveal the presence of normal function when symptoms suggest otherwise. So the patient's complaining of marked visual acuity loss, everything's completely normal, we've done our job to a certain extent. And you need to use various different forms of tests. Now this is a patient who had trauma, she was in a car crash, it wasn't her fault, she was suing the driver of the car that was responsible for the crash, so there's a lot of money at stake if her counting fingers vision is genuine. And she's counting fingers on the right, 6, 5 on the left. The left eye VP is completely normal, and the right eye pattern VP is delayed and reduced. Pattern ERG is done binoculairly and normal. So when we look at this, we think, that's abnormal. But then you think, wait a minute. This is a patient who's only got counting fingers vision. How can an eye with counting fingers vision look at a pattern which has got small black and white checks and get a response to the brain? Not possible. So the question then is this patient exaggerating genuine visual loss? In fact, the patients are always observed. There's a technician who watches the patient. This was done in Moorfields, where we have a camera on the patient all the time. And the technician saw what the patient was doing when testing was taking place. All this kind of stuff. Half closing the eye, deliberately defocusing, etc., etc. And when another technician stood in front of her and said, keep looking at the screen, keep your eye open, and got the test done properly, the VEP is completely normal. Because this is deliberate manipulation by the patient. And you've got to remember that when you're doing this kind of testing, patients are patients. You ask a patient to do something, they won't necessarily do it. We've all seen this. You take somebody, look left, they look right, open your eyes, they close their eyes. We've all seen it. It happens all the time. But for some reason or other, when they're doing VEPs, people expect them to behave better. Not true. So always be cautious about the patient's ability to comply. 7-year-old with behavioural problems, attending a special school because of behavioural problems. Bilateral acuity loss following a change of teacher, referred non-organic. And I knew the ophthalmologist very well who sent the patient. I saw the referral. I thought, why is Mary sending me? This patient's got non-organic. Fundi were normal, and they were passed as normal by David Taylor at Great Ormond Street. Some of you will know David's name, he's probably the world's most eminent, along with Craig Hoyt, paediatric ophthalmologist. And we'd done the VEPs, which were virtually undetectable to a pattern, and with flash, they were present but okay. So you then say, oh, wait a minute, this is a child who's got behavioural problems. How do we know that the child is looking at the screen? We've already seen that you can get abnormal VEPs as a consequence of poor compliance. But when you do P50, you've got two different components. P50 is driven by the macular photoreceptors. So when you see a normal P50, which you see in both eyes, you know, firstly, there cannot be significant refractivity. Secondly, the patient is compliant. And thirdly, the macular function is fantastic. So this becomes genuine. In addition, you then see the M95, which should come down below the baseline, shows repetitive loss. So the patient's got ganglion cell dysfunction in association with bilateral optic neuropathy. The next day, the patient was due to see the psychiatrist. That was changed to see the neuroradiologist, and that was normal. And it's at that occasion that the patient got sent up to Great Ormond Street. I was working out in the periphery, and the patient was sent up to David. And David did all the necessary investigations, and the child had the 11-778 labour hereditary optic neuropathy, the most common mutation, with a normal fundus. Labour disease, of course, usually you get left with this pale disc, and in the acute phase you get telangiectasis of the vessels on the disc. That resolves, and then the disc pattern occurs. So that's what happens in progression. Three most common mutations. Paul Ridley's very nice paper indicated age 6 to 62. Speaking to Nancy Newman, who's probably the world's leading labour disease expert, she's seen patients from ages of 1 to 82 at presentation with labour hereditary optic neuropathy with mutation. Now this patient was assumed to be non-organic because he's a doctor. And he had poor distance vision, and he had good near vision. Nothing much to see. The autofluorescence was passed as normal, might be slightly suspicious. And his VEP was broadened and distorted. His pattern RG was markedly reduced, so this is not non-organic. When we do his ERGs, he's got a big peak time shift in the flicker ERG, so he's got generalized cone system dysfunction. Pattern ERG both to a small and large field, markedly subnormal, so he's got a cone dystrophy phenotype. And then when you look at the OCT, he's got very subtle changes in his right eye, which aren't very well seen because it's a full scan, but there's a very clear localized defect in the ellipsoid on the left. And this is very typical of mutation in RP101, which Miyake first described as occult macular dystrophy. It's occult because when you look at the macula, you don't see anything, and this was confirmed mutation. So the doctor was not non-organic, but it's very easy to miss this. If you get a bad scan, or you just go one line above either direction, you won't see it. Always get functional correlates first before making a diagnosis of non-organic issues. Patient with a traumatic optic neuropathy comes in with difficulty seeing at night. Pale disc, loss of ganglion cell layer on the OCT, absolutely in keeping with a traumatic optic nerve disease. When we look at the electrophysiology, he's got no pattern BP, he's got that shape that we've already seen, what happens when you lose ganglion cells completely. P50, small, shortened, tailing off. Shape is important, but it doesn't explain the night blindness. When we look at the signals, this explains the night blindness. Rod specific ERG undetectable, bright flash ERG very small, cones normal. It's all down to history and identification of the origins of the signals. Because once we look at the retina in a different way, we wait for our DA red to come. He's got a cone component, he's got no rod component at all. So these signals here are coming from dark adaptive cones. They haven't flipped over into the B wave being smaller than the A wave. Some patients do, some patients don't. All we can do is say that it's coming from dark adaptive cones. And then you go back and you take the history which should have been taken properly to start with, but which wasn't. And the people have had the Whipple procedure, pancreatic tumour, and of course if you lose pancreatic function, you lose your digestive enzymes, you lose the ability to absorb fat soluble vitamins, and this is another case of vitamin A deficiency. And following replacement therapy, complete normalization. And this process, if you give it intramuscularly, usually takes about 2, maybe 2.5 days to get virtually complete recovery of the rod system. S-scans take about 10 or 12 days. 42-year-old, sudden onset of bilateral acuity loss, ex-intravenous drug user, missed appointments for ERG. No surprise, these are not reliable patients. Eventually he turns up, he's got PL in both eyes with minor fundus changes. You look at the autofluorescence and you think, well, yeah, okay. And you look at the optos and you think, okay. But then when you look closely, you can see there are sort of white dot lesions of unknown origin in both eyes. So he's got abnormalities in his retina. There are hypofluorescent changes in both eyes in the autofluorescence. And his OCT contains abnormalities. So he's got retinal abnormalities. And we do a pattern VP and it's undetectable, and that turns out to be because he's got no detectable pattern ERG. So those macular abnormalities, even though they don't look much on the imaging, are actually quite marked. So we do our ERG, and ERGs are normal. But what I didn't show is that when you do a VP, you don't just use a pattern reversal, you always use a flash as well. The flash is virtually undetectable from the left eye and markedly abnormal on the right. The patient has normal retinal function, but abnormal macular function. Abnormal macular function, where you just got a small area of retina not working, will not cause a flash VEP abnormality, which is this profound. So, telephone call was made, patient was recalled for an urgent MR. Patient actually has a large intracranial mass, so he's got dual pathology. Fundus appearance does not explain the symptoms. Macular disease explains the loss of the pattern ERG, but does not explain the flash VEP. And flash VEPs, kind of, they're old-fashioned technology. Why do we still do flash VEPs? Because they give us information that a pattern VEP doesn't. This patient, disturbed vision, thought to be non-organic in origin, pattern VEP is completely normal, and the ophthalmologist who referred the patient said, look, to be honest, Graham, the only reason I'm referring her is that she's a private patient. I've got to be seen to be doing something. I don't think there's anything wrong. Not the way to practice medicine, but that was the reality. Pattern VEP is completely normal. Flash VEP? No. Flash VEP, profoundly abnormal, markedly reduced, changes in wave shape, and because you can get this appearance in nerve sheath disease, the patient was injured. And the MRI showed a cavernous sinus meningioma tracking into the orbit, with the only initial signs electrophysiologically being an abnormal flash VEP. 1 year later, pattern VEP changes occurred, and 1 year later there was M95 loss in pattern RG. But all this was picked up because of a flash VEP. Old-fashioned, yes. Clinically useful, maybe 10% of the time, but in those 10%, I would want to be one of those 10% of patients. Now this is a patient, and you can see this was referred by a neurologist, sudden onset of left visual acuity loss. She was walking along the street and lost vision. She didn't come to the hospital, which was Tangkok Seng here in Singapore, until 2 weeks later. And that's when these were taken. It was assumed to be an acute optic neuropathy, so they did the necessary optic nerve measurements, and there were no structural changes visible. Clinically, everything's fine, the nuclear sclerosis, but had a grade 2 IED. So this was assumed to be an optic neuropathy. She was admitted for consideration of steroids, but the MRI showed nothing much, just a little bit of old ischemic disease. And that's when they asked for the electrophysiology. Those were fields. So it looks ischemic. We do the VEP, and it's delayed. So we've got evidence which could support an optic neuropathy. Until we do the pattern RG, which is completely undetectable. So it is not optic nerve disease. So this then starts retinal investigations. Now the ERGs were interesting because they're very subtle in terms of picking up an abnormality. There is a very marginal delay in the flickering ERG. So there is some retinal cone system dysfunction. There's a mild reduction in the B-to-A ratio in the single flash, which is not clinically significant. Definitely within the context of this, probably adopts that. But what we do see also, these are syllogisms, these small little wavelets on the B-wall are markedly reduced in the left eye. These are very sensitive to ischemic disease. So the possibility that this might be vascular in the retina rather than the nerve was encountered and reported out. Multifocal ERG just showed generalized changes in the left eye. OCT now, looking at macular OCT rather than anything to do with the nerve, shows generalized thickening here. So this looks like a central retinal artery occlusion. When we look here, you can now see on the false colors a sclerotic vessel, which shows nicely. And then when you do the fluorescein, first they're filling here earlier than the inferior, and then watch this vessel here, where you see the classic box scarring. So the patients have a central retinal artery which is then refused. But without the electrophysiology to point to the retina, the patient is going to have steroids because of the extrapolyneuritis. And this was a case which we literally, this was 5th of May this year, so it's very recent. Patient here, who was referred by a world-famous neurologist, demyelinating optic neuritis, right eye. What was the extent of the recovery? And the patient was part of a trial, had already been started on steroids, periorbital pain, started centrally, and the VEP was just about detectable, very delayed, very small. Flash VEP, very distorted and delayed. Pattern ERG, completely undetectable. It was not optic neuritis. So you then have to go down the retinal route. Look very carefully here. There are subtle changes centrally. There's loss of reflectivity of the ellipsoid, and the diagnosis may have presumed AMN and steroids have stopped. Patient came back. We've now got very hyperaural fluorescence, similar to that which you see in Azure. And now we've got definite hyperreflectivity. Now that doesn't mean the photoreceptors have come and gone, or sorry, gone and come back. You've got to remember that when you're doing an OCT, you are not looking at anatomy. You're looking at changes in reflectivity and reflectance, transmission of ultrasound signals. So all we're looking at here is changes in that reflectivity and changes in transmission. It doesn't necessarily tell us we have lost a structure which has then come back. It's just the reflective nature of the structure has changed. And we all know that if you angle a patient differently than an OCT, you can see things differently. So the patient came back and had retinal examination, showed a delayed flickering RG, so there's a generalized retinal loss in the cone system. The patient came back, peripapillary hyperautofluorescence is remaining, but the other eye is now starting to develop changes, and this is presumed now Mazur. And note that this has been pretty good recovery, but now we're losing it either side, and these are reflectivity changes. And we've now got mild flicker delay in the left eye, so this is Azure, which is progressive. Marked abnormality on multifocal. Another patient with Azure, again, this is the asymptomatic eye with peripapillary hyperautofluorescence and a peripheral retinal lesion. And Optos can sometimes be very useful because it shows you much further out than the spectrometer. Okay, it looks as if the patient's got alien blood, but you get used to it. And this was the eye which was symptomatic. We've got this area here, and from the patient you'll recall with carcinoma-associated retinopathy earlier, dark tends to be better than light. Because the problem here is always, okay, which is the normal? Working on the assumption that this is the normal part, this therefore becomes the abnormal part, that's obviously abnormal. So when we look at the OCT, we look at the corresponding area here, quite clearly there's loss of outer retinal structure, which you could say fairly definitely because of all the curvature changes. And there's loss here, and here corresponding to the peripapillary hyperautofluorescence. We've got loss of outer retinal structures. And the patient's got a delayed flickering RG bilaterally. This eye is asymptomatic, this eye is symptomatic. And it was Diana Thomas's case, and she decided that she had no choice but to give the patient some treatment because she had no idea what to do. There are no randomized controlled trials for Azure in the literature. There are anecdotal cases only. But she treated with stimulants. Oh, sorry, multifocal shows that if you look here, there's the corresponding area of preservation. And loss here, corresponding with that. During the time that she was being treated, the right eye deteriorated. The left eye stayed unchanged, and indeed electrically, the left eye completely normalized. Anecdotal, but perhaps if you get there early enough in Azure, you might be able to affect the course of the disorder. Perhaps. The right eye continued to deteriorate, and that continued, and then when we look at follow-up, now over a 2-and-a-bit-year period, this is what happens. Gradually the hyperautofluorescent area disappears, and then you get these mottled appearance, almost like jigsaw puzzle pieces, until you get here, the case which looks, and you'd be forgiven for saying, this would be unilateral pigmentary retinopathy, and indeed some people might describe this as so-called unilateral RP. But if you look at the world literature, there is one case only in the world literature, unilateral RP, which is genetically confirmed. Just one case. And we've got a series of 40 to 50 patients, the majority are post-inflammatory or post-traumatic. These are all patients who've got what we think of as Azure. Sometimes it's unilateral, sometimes it's bilateral, but these are the type of images that alert you to autoimmune disease, this kind of patchy, and you look at these and you think, well, how many different shades of autofluorescence are there? There's very black, there's grey, there's light grey, there's light, there's white. They're all there in the same image. And trying to work out which are the normal bits and which are the abnormal bits is not easy. More patients here with what's assumed to be a zero. And just to end with one case, 56-year-old head injury. Hit near his right eye by falling wood while at work, trauma recovered, he was complaining then, or he was found to have constricted vision fields. And this is cutting out. 1, 2. Fundai were normal, acuities were normal, referred by a neuro-ophthalmologist. And his VEPs were slightly delayed, had bilateral maculopathy, explaining the acuity loss. Is it related to the trauma? Well, we can't say anything at the moment. We've only got what's going on in the macula. Now we need to look at what's going on in the retina. When we look at the retina, we see a different story. Because the rod-specific ERGs are bilaterally subnormal, bright flash ERGs are profoundly electronegative and lack the oscillatory potentials. Flicker ERG is delayed, so this is major inner retinal disease in the rod system and in the cone system. And then again, it all boiled down to a technician taking an accurate history. Technician. Because the patient is epileptic, the patient was taking vigabatrin, which is an anticonvulsant, which is associated with an inner retinopathy, and the patient simply has vigabatrin toxicity. The neuro-ophthalmologist hadn't considered the anti-epileptic medication because it wasn't asked. The technician said, "Oh, are you taking any drugs?" Vigabatrin. Technician, the lights came on in his head, but the neuro-ophthalmologist hadn't asked the same question, and the lights had got set off. So, to conclude, why do we do electrophysiology? Well, we've seen lots of examples now, both in inherited and acquired disease, because it gives us objective function. You must take an accurate and comprehensive history, examination, etc., and don't forget that when the technician does the ERGs, they might be able to give you useful information because they're with the patient for longer than you are. You will ask the patient questions, any of your family members affected similarly? The patient says no. The patient goes home, gets on the phone and says, "Oh, didn't Uncle Charlie have some problems?" And they come out with the family history, which will then get told to the technician. And the technician can then pursue those questions, providing the technicians are trained to take histories properly. Normal fundus does not mean normal function, and by normal fundus that also means normal OCT, normal autofluorescence. Signs may not correlate with dysfunction. Signs may be worse, signs may be less. Always relate the two. VEP delay, and this is really important because you're taking one message from this talk, VEP delay does not mean optic nerve disease, and of course, in the context of non-organic visual loss, the symptom may not even mean disease. So, thank you very much. And we should have time for questions. I will take questions on any aspect of electrophysiology or anything at all, no matter how crazy it seems. Remember that there is no such thing as a silly question. Stupidity when it comes to questions lie in the person who seeks an answer but doesn't ask the question. So if you want to know something, now is your chance to ask. Because when I walk out the door, you can't ask the question. Although I will stay for lunch, so you can. Well, let's see. Somebody somewhere must have something. Oh, thank you.
Thank you, sir. As far as the approach to electrophysiology is concerned, when a patient walks in and you see something abnormal in the retina or the macula, you order an ERG, either a full field ERG or a pattern ERG or a multifocal ERG. But if the ocular examination is by and large normal, you cannot find anything, then you go ahead, you get the VEP, the ERG, all the different types of VEPs and ERGs.
It depends on what the symptoms are, and it depends on what the signs are when you look in the eye to start. So if the patient is 68 years of age or 78 years of age, and there's lots of drusen and there's geographic atrophy on one side, there's wet AMD on the other side, this patient does not need electrophysiological examination. So if you've got a very clear diagnosis, the history is consistent, examination is consistent, symptoms are consistent, you don't need electrophysiology if you've already worked out what it is. What you need electrophysiology for is when you don't know what it is. When you see something you don't recognize, when there are inconsistencies in what you think you should get and what you see, then you ask for the electrophysiology. And the way the electrophysiology is done should relate to the symptoms. So if the patient's complaining of night blindness, you don't need to do a reading because it's not going to be due to optic nerve disease. If they've lost visual acuity, then you'll need a pattern ERG, you'll need a pattern DVP. And if the pattern ERG shows you maculopathy, then you need an ERG. If you've got positive phenomena, you're going to need full field ERG no matter what. So it really depends on what the nature of the symptoms are. You try and utilize the symptoms to localize to a given system, cone system, rod system, macula versus peripheral retina, to give you the most appropriate and you investigate appropriately. But you don't do everything on everything. That's not cost effective.
Thank you.
We use the flash VP. I actually have a two-part question, so this is regarding the flash VP. We generally use the flash VP for traumatic optic neuropathies. So we have our ENT colleagues at our center back in India actually do a lot of optic nerve decompression. They have a large series on patients treated with IV methylprednisolone, which is still debatable. But the idea is a patient gets traumatic optic neuropathy, indirect traumatic optic neuropathy. The vision is light perception negative with the indirect check with all the ways possible. The question is they would like to get a flash VP done to look for any kind of waveform, and then maybe give the patient a trial under very guarded circumstances of optic nerve decompression, as opposed to if there's absolutely no waveform on the, or a completely flat waveform on the flash VP, do not offer that surgery. Is there a better way to look at that sir, or?
No, I don't think so. Providing you've exercised the necessary caution, and in the patient with no detectable VEP, you have demonstrated intact retinal function. Because you can get traumatic retinopathy as an association with the optic neuropathy, you get a traumatic artery occlusion or whatever. Just need to make sure that your retina is working before you draw conclusions about the VEP, because the VEP comes later. But other than that, sure. When I was working at Moorfields, Hank Kaur is most of you have heard of Hank. He operates on pediatric glaucoma cases where it's virtually, it's heroic surgery. And he doesn't want to go in at all unless we can demonstrate something's reaching the cortex. If we can demonstrate something reaching the cortex, then he will operate. But if everything's flat and there's still retinal activity, there's not a lot.
Another extension of the same thing. So we also use the flash VEP because we get a lot of referrals from, we have a very strong pediatric center at our hospital. We get a lot of referrals from the pediatric neurology clinic, and they send in patients with what they feel is unexplained vision loss because the parents will come, get the kid, and I'm talking about really young kids there, 7, 8 months, 1 year, 2 years, maybe about 3 years old, in which the fixation is not right, they're not following, not holding objects properly, and then they do a direct examination and maybe say that there's some kind of a disc pattern, and then you can go from there. So we try and do a flash VEP for them. I don't know how to go forward with such a thing, because how do you image a kid that's that young and has no other?
But doing a flash VEP in a kid that young is easy.
We do that, so but do we interpret it similar to the way we do, let's say, a traumatic optic neuropathy case? Because
no, it depends on the clinical question. Because in that instance, you've got, have we got a child, we've got delayed visual, let's assume the kid's less than 9 months old. You're looking, is it delayed visual maturation? Is it retinal disease, early onset retinal dystrophy? Is there associated eye movement disorder? Is there roving eyes, could it be labeled congenital amaurosis? Is there nystagmus, could it be cone dystrophy, early onset cone dystrophy? So the clinical question you're asking in a baby is is very, very different from that which you're asking an adult. You're not looking for rod system sensitivity. We had a kid earlier this week with microcephaly, and the question then was basically what's getting through, and the VUPs were just about present, and the ERG was good. But when you do the ERG, you do skin electrodes on the lower lid. You don't have to dilate the pupil because you're not looking for subtle changes. It's, if you like, it's almost it's a binary choice almost. Is there an ERG, yes or no? If there's no ERG, then you've got something like latent germinosis. If you've got intact conal flicker with normal timing and normal size, you've excluded generalized cone dysfunction. If you've got no ERG under light adaptation, you do it under 5 minutes dark adaptation with a very bright flash to see whether you've got electromagnetic blood flow. But you can only interpret the V in the context of the retinal findings. So if you've got the child who can't see, the fact that the fundus looks normal does not exclude an early onset retinal dystrophy, because those changes may not occur until later. And if they've got RPE65 mutation, fundus is going to be normal early on anyway. So doing a VUP in a kid that age, actually very easy. We do the ERGs handheld, we're using a handheld stimulator, we're not sedated, kid sits on mom's lap, kid gets followed around with the technician, child moving like that, the light goes like that. You're not interested in the subtle defect, you want to know whether there's a flicker, etc., etc. And then with the VUP, that's pretty easy to record because in most kids they're large signals, and then you can use the two together. So it's not quite the same as the trauma case, because the trauma case, you've got an established diagnosis, and the question is how much function is there. In the child, you've got unexplained visual loss, so you need to consider all aspects of visual pathway, which could be involved.
If someone diagnosed retinitis pigmentosa, if he doesn't have the ERG, do you think it's necessary to send the patient for ERG to confirm the diagnosis? And what additional information can we get from ERG?
It depends on what basis the diagnosis has been made. If the patient has a positive family history with affected family members and is mutationally confirmed in the family, then the information that you will get by doing the ERG is severity and how much the disease has progressed. If you don't have a positive family history, how was the diagnosis made? The presence of intraretinal bone spicules does not equal RP. It could be post-inflammatory, it could be post-traumatic, it could be an Azure type disorder which has progressed. We saw in the last case of the Azure, where when you monitor it, 2 years down the track, it looks like unilateral RP. So it depends on the criteria that you're using to establish a diagnosis in the first place. Is it bilateral? Is it symmetrical? If there's a family history, does it match the other family members, etc., etc. But simply the presence of intraretinal bone spicules and constricted visual field does not mean the patient's got an inherited disorder. So the answer is yes, you need me under some circumstances, but not under all. If you know, but as we saw earlier on as well, with the 12-year-old, family history of RP, comes in with night blindness, you do the ERG, if you just simply made the diagnosis of RP, which they had, because it got a positive family history as night blind, you missed the vitamin A deficiency, which is treatable. So it depends exactly what the signs and symptoms are, what other information you have, before you decide whether to do the electrophysiology or not. I mean, it won't be necessary in all patients, but in some it probably is.
Good morning, Dr. Graham. It was a beautiful presentation by you. I hope I am able to understand some of it. So my question is somewhat related to the question which was asked earlier. Is VP concerned to some extent with the RNFL thickness? Since this was asked by one of my colleagues, that can you operate a drawn case or optic nerve decompression in case of a PL negative patient, seeing that the VPs are flat and still we have a good INFL thickness. So does these two things correlate or not at all? Since we are seeing the same fibers which are going from the retina to tracing that nerve later.
Yeah, but by far the easiest way of looking at it is to use a pathology, because the pathology will tell you about retinal ganglion cell function. The relevance is not so much there in terms of trauma, because if you don't believe it and you do have a functioning retina, then you know the damage must be behind the retina, and you treat it appropriately. The issue may come in something like a family toxicity, where you've got a toxicological neuropathy. And there, if you can establish you've got a VEP delay, and you've got a normal pattern G, then that patient has a good prognosis for recovery of function. Because if you stop your family toll, you haven't got evidence of retrograde degeneration to the ganglion cells. From the optic neuropathy, then 95 is normal. So you can keep fingers crossed, and with luck, we've had one patient who recovered from 636 to 66 after 8-9 months cessation of the family toll. But if you've already got N95 loss, then the prognosis for recovery of vision following the cessation of the drug is poor. And you can also do that with mature tumors. Neurosurgeons sometimes like a little bit of advice. It won't stop them doing what they do, which is operating, because that's what they do. But every now and then they like a little bit of advice on what's happening.
Thank you.
Any more questions? Okay. Thank you very much, Professor Uller. Probably is here, but I think he's probably just grab some things. If you need to go to the restroom, you can do it. Quick one and come back. Thank you.